Our goal is we want to maximize quality care for people who come to our center while also reducing the healthcare costs. And part of that is, avoiding preventable ER usage or hospitalization. So medical respite is kind of like this novel thing that we don't really have much of in New York. So we're curious to see more about it. And so Boston has been doing it for about 30 years. They're probably one of the oldest medical respites in the country. So they first started in a shelter providing respite care, and then they moved into a 20-bed site, and then they bought the current building for $1 from the city, and that is now home to this 104-bed site. So if I could just paint the picture a little bit of this neighborhood. So you have the Boston Medical Group, which is this huge hospital campus, and it's kind of surrounded by major roads, like a big highway intersection, and you've got tons of homeless people just kind of congregating around there. And it's kind of cute in the way they're hanging out together, having their coffee in the morning, smoking a cigarette. And as you approach the respite, which is right across the street from this major hospital, there's just people just all outside hanging out. And I guess it's just kind of speaks to that this respite is their home in a way. This is the place that they can come to and feel safe, or they have their little community there. So if you walk into the respite itself, the first floor is actually a FQHC, just like ours. It's a federally qualified health center where they can come and get health care. And there's also a room where if they're using substances, they can be monitored. So, if any need for safety, there's a nurse that can assist them. And so from the FQHC, that's the first floor. The second through the fourth floors is the actual medical respite. So the second floor is kind of the group area. It houses a cafeteria, a laundry, activity room, a rec space where if they want to have groups, they can meet. And then the third to the fourth floors is the, more of the inpatient place where it kind of appears like a hospital, and that's where the 104 beds lie. And it's very, very busy. So their annual budget is about 16 to 18 million. They have approximately 2,500 annual admissions with about 12 to 1,800 unique patients each year. Like I said, they have 104 beds, they have a pharmacy on site. And so with the staffing, basically as it works there, is that every day each patient gets a touch point with a medical provider and 3 visits from nurses. So it's very involved with medical care. And it doesn't matter what you're there for, everybody gets those 4 touch points every day. And the teams also include, besides the primary care physician, they have a registered nurse, they have a case manager, they have medical assistants, they have social workers, psychiatrists, and so a total of about 175 staff for this respite. Now, the criteria for admissions is kind of, as they called it, too sick for shelter, but not too sick for the hospital. Or another way they said it is, imagine needing to discharge someone home with visiting nurse service, only they have no home to go to. So admissions can include things from as simple as colonoscopy prep the day before an actual colonoscopy, so it's preventive care, to something more extreme such as palliative care for towards end of life. Their average stay is about 2 weeks, but they have no mandatory end. So they have had people there close to pushing a year. All right. So they have about 10% daily turnover. They have embedded nurses at the hospitals in the vicinity. So they partner with the inpatient unit there on criteria and admissions to transition those hospitalized folk into the respite. While they're there, they're getting their care, and then usually towards the end, they get a discharge plan with the case managers. And most of these people, they end up going back to the shelter, back to the street, Boston doesn't have a very robust housing system, not as great as New York, but so yeah, people kind of just end up back out after they get their care. As far as outcomes data goes, it's been really hard to track because there's so many hospitals involved with this partnership. But Boston Mass General did report that by being able to transition these folk out of the inpatient into respite, then they're able to free up beds for, other patients. So in a way that kind of helps with their revenue because they can have that turnover. Because they're very medically intensive, they are able to bill for the physician's visit and the nursing visits. So they're able to bill patients' insurance companies. So bulk of their revenue comes from there. Of course, they still see uninsured, but they have like this payer mix and they kind of have figured out the game of how to stay afloat. Another way that they get revenue is having a contract with certain hospitals to have like a certain number of bed days allocated to them so that hospital has guaranteed beds for their patients. And then they also do fundraising throughout the year. But the bulk is from billing insurance, which in New York might not be the case for us here. So we would have to be a little bit more creative with how we're going to fund respite here, but that's how they do it there.